So another issue that comes up all the time in oncology, and again, I mean, this is not like this 5 years ago, is testing. Not just tissue testing, but now you have the whole arena of liquid testing, liquid biopsy, tumor-informed cell-free DNA, and MRD. And let's talk a little bit about HER2 positive upper GI cancer. And of course, one of the issues here is you all already have a lot of experience with HER2 positive disease from breast cancer that the GI people don't. And one of the things that I've been hearing that I thought was really interesting, and Swati, I'm curious what you think about this next comment, is I brought up to him the fact that I see these GI investigators, the patients diagnosed with HER2 positive disease, they get first line therapy now with Pembro, trastuzumab, chemo. They have progression, and then they repeat the HER2 testing, either tissue, liquid, or both. And if it's negative, they don't use HER2. Where to me, I think what I'm hearing from the breast people for the last 10 years is once you're HER2 positive, you're HER2 positive. I don't know who's right. And I think, I mean, he alludes to some data that supports what they're doing. But anyhow, here's what he had to say.
That's based primarily on a bunch of studies that have shown that for whatever reason, there is a group of patients that do not retain HER2 beyond progression. And it could be a quarter of them, it could be 30%. Studies have looked at this now in a bunch of smaller studies, but even some randomized phase 2 studies that have shown that's the case. Now, primarily that's been done based on tissue. Those studies are tissue diagnostics. However, because we recognize in the real world the challenges of repeat biopsying everybody, people have gravitated to ctDNA in that context. I agree. My personal preference is still, if they progress on frontline trastuzumab-based therapy, to consider repeat biopsy when making that second line decision. I try to do it, let's put it that way. And if I can't, I do ctDNA as a surrogate.
Any thoughts, Swati? You know, it's so interesting when you see agents crossing tumor lines, and now, you see the lung people are dealing with HER2, the GI people, not just upper GI, but colorectal. But you all are already coming in with a long history of the anti-HER therapy, using a lot of these agents. Any thoughts about the challenges in these situations, and particularly these issues of repeat biopsies and type of biopsies that really are a part of oncology nowadays?
So I see your point about us not repeating the biopsy in breast cancer, whereas in GI cancers where we do. And I think this also is important to understand that the way drugs work in different tumor types is probably different, and it's not the same in every cancer type. The classic example with TDM1, we have data it works in breast cancer, but it doesn't really work in gastric malignancies. So I think we cannot always concur that if something works in one tumor type, it always has to work in another tumor type. And from what I understand, 20 to 30% patients do lose HER2 on second line. So I think it is important to rebiopsy patients, especially if I'm thinking of a drug like trastuzumab deruxtecan, which has a lot of toxicities. So I don't want to be using it till I'm absolutely sure the patient's going to have benefit. I mean, I'm not sure about the data in GI cancers with HER2 low and TDXT like in breast. So far, I know they have to have the conventional 3+ IHC fish amplification to get it in the second line setting. So I personally would biopsy patients if I can. Otherwise, use liquid biopsy before I talk to them about agents like trastuzumab deruxtecan in the second line setting. That's my personal opinion. I would not continue HER2 treatments without rebiopsy.
So speaking of TDXD, that was the next thing I asked about, which really basically second line therapy of HER2 positive upper GI cancers. Again, interesting to talk to different investigators about their perception. TDXD, I thought targeted therapy was fairly straightforward until and HER2 low came out. That completely shattered my whole view of what targeted therapy is to start with. Anyhow, here's Dr. Wainberg answering the question of what his approach to second line therapy is in a patient who retains their HER2 status after chemo, trastuzumab, and pembrolizumab.
If someone's HER2 positive right now and I confirm HER2 positivity, I am using trastuzumab deruxtecan. Based also on the accelerated approval, they have a randomized phase 2 study that showed a benefit of survival in Asia in that context. We have complementary data in the Western world showing response rate and PFS benefits similar magnitude with trastuzumab deruxtecan.